Hello, I heartily welcome. My name is Kurt Huber. I'm an interventional cardiologist from Vienna, Austria, and I would like to present you the EC guidelines for the management of non-ST elevation acute coronary syndromes, the part of the invasive management. These are my disclosures. The EC guidelines for the management of acute coronary syndromes in patients presenting without persistent ST segment elevation have been published in 2011. The main responsible chairpersons, were Christian Hamm from Germany and Jean-Pierre Basson from France. I was also part of this guideline committee. First, I would like to explain to you the classes of recommendations that have been made and that are usual for the European Society of Cardiology. A class of recommendation number 1 means that there is evidence and/or general agreement that a given treatment or procedure is beneficial, useful, and effective. Within class 2, there are two options, 2A or 2B. 2 means that there is conflicting evidence and/or a divergence of opinion about the usefulness or efficacy of the given treatment or procedure. 2A is a bit better. There is weight of evidence or opinion in favor of usefulness efficacy. And B, usefulness efficacy is less well established by evidence or opinion. And 3 is the situation where the evidence or general agreement that the given treatment or procedure is not useful or effective, and in some cases also may be harmful. In addition to these recommendations, we have 3 different levels of evidence, A, B, or C. A means that data are derived from multiple randomized clinical trials or meta-analysis. B means that data are derived from a single randomized clinical trial or large non-randomized studies. And C is consensus of opinion of the experts and/or small studies, retrospective studies, or registries. To treat patients with non-ST elevation MI, it is important to define the high-risk features for recurrent ischemic events. We have 3 options to do that. First, the clinical evaluation of the patient. A patient with multiple episodes of pain or documented ischemia. A patient with hypertension, renal dysfunction, or diabetes. A patient with refractory ischemia with ECG changes despite treatment. And patients with prior heart failure revascularization. Electrocardiographic signs for high risk is a transient ST segment elevation, a T-wave inversion of more than 2 mm in multiple precordial leads, a new left bundle branch block, and sustained ventricular tachycardia. And we have also an important specific biomarker, troponin. And if troponin is above the 99th percentile reference level, we think that the patient has a acute coronary syndrome. The guidance of therapeutic strategies in patients presenting with non-STEMI is shown on this slide. And I would like to start with the lower part. So which patients can be treated conservatively? So this is patients with a low risk score. There are different risk scores available, and you will see some examples a bit later in this presentation, like the TIMI or the GRACE risk score. Also, patients or physicians' pre-reference is important in the absence of high-risk features. So the low-risk patient is a patient you primarily could treat with a conservative, only medicamentouse strategy. What about the need for an invasive strategy? This is for patients with recurrent angina or ischemia at rest with low-level activities despite intensive medical therapy. Patients with elevated cardiac biomarkers, troponin T or I. New or presumable new ST segment depressions. Signs or symptoms of heart failure or new worsening mitral regurgitation. Hemodynamic instability, sustained ventricular tachycardia, percutaneous coronary intervention within the past 6 months, previous coronary artery bypass surgery, a high risk score, and a reduced left ventricular function of less than 40%. The criteria for high risk with indication for an invasive management are summarized here again. So primary invasive management, a relevant rise or fall in troponin, dynamic ST or T wave changes in symptomatic or also silent symptoms. And secondary features are diabetes, renal failure, reduced left ventricular function, early post-infarction angina, recent PCI, prior coronary artery bypass grafting, and intermediate to high Gray's risk score. This is a flow diagram with respect to the rapid rule out of acute coronary syndromes with high sensitivity troponin. So patients with acute chest pain get an invitation of a high sensitive troponin. It doesn't matter whether it's troponin I or troponin T. If the pain is more than 6 hours prior to the situation where the patient comes to the hospital, then there is, and the patient now is pain-free, has a relatively low risk score, for example, a Gray's risk score of less than 140. And if also differential diagnoses have been excluded, this is a low-risk patient, and you could discharge him from hospital, but this patient should go for stress testing within the next few days. If the pain was within 6 hours of presentation in the hospital, and the first troponin would be below the cutoff, then you have to retest troponin within the next 3 hours. If there is no change, the troponin stays negative. This is a low-risk patient, and you can discharge him with the stress testing thereafter. But if the patient has, in the initial measurement, a positive troponin, in this situation, the patient has to go to an invasive management, and it depends on different variables whether this has to be immediately or you can have some time to do these investigations. A patient who comes in with an initial negative troponin but develops a positive troponin within the next 3 hours, so he has a clear delta, an increase of troponin levels, is also a patient who should go for an invasive treatment. There's also patients who have initially an elevated troponin. There is no change in the troponin after the first testing, and this is a patient where you have to do a decision on an individual basis. Now there are different other decision-making algorithms in acute coronary syndrome, and these algorithms include a clinical evaluation, then a diagnosis and risk assessment, and finally, if necessary, coronary angiography as diagnostic method. Clinical evaluation means that the quality of chest pain is important. Symptom-oriented physical examination is important, so not all typical locations of chest pain mean that this comes from the coronaries. A short history for the likelihood of coronary artery disease is important. So, for example, is there an increase of pain within the last few days? And you do also an electrocardiographic elevation. For example, you look for ST elevation or ST depression. So if you don't see anything in the ECG, if there's no typical pain, if there's no risk factors, the likelihood for coronary artery disease is low. If, however, there is an ST segment elevation, this means that the patient has an acute ST elevation myocardial infarction, and immediate emergent reperfusion strategy has to be taken. If an acute coronary syndrome is possible, then there are 3 different options how fast you should react. So if you think this is a high-risk patient, a typical situation would be a patient with signs of ischemia in the electrocardiogram, or with ongoing typical chest pain and a typical risk stratification with a high-risk feature, then you should not wait, and you should go for an urgent angiogram within 2 hours. But the diagnosis and risk assessment could also show us a patient who is not as acute. If the patient responses to antiangular treatment, if there are not typical signs in the ECG, if the biochemistry with respect to troponin elevation is not quite clear, also if an echocardiogram shows a completely normal left ventricular function, and if you look at different risk scores, and these scores are not extremely high, then there's an opportunity to go for an early, within 24-hour angiogram, or for an early angiogram within 72 hours. And this gives you also the option to transfer a patient from one hospital, which has no catheter facilities, to a PCI-staffed hospital. Now, what do the guidelines say? And please remember the recommendations and levels of evidence. The guidelines tell us that an invasive strategy within 72 hours after first presentation is indicated in patients with at least one high-risk criterion and recurrent symptoms. So this is a 1A classification. An urgent coronary angiography within 2 hours is recommended in patients at very high ischemic risk, patients with refractory angina with associated heart failure, life-threatening ventricular arrhythmias, or hemodynamic instability. And this is a 1C recommendation. C means that we don't have clinical trials that support this recommendation by experts. An early invasive strategy within 24 hours is recommended in patients with an increased risk score, for example with a Gray score of more than 140, or with at least one primary high-risk criterion, 1A. Non-invasive documentation of inducible ischemia is recommended in low-risk patients. So this is the stress testing I referred for 3 slides ago, without recurrent symptoms before deciding for invasive evaluation, again a 1A. The revascularization strategy, whether it's an ad hoc culprit lesion PCI, a multivessel PCI, or a coronary artery bypass surgery, should be based on the clinical status as well as the disease severity, for example distribution and angiographic lesion characteristics, according to the local heart team protocol, a 1C recommendation. And as there are no safety concerns related to the use of drug-eluting stents in acute coronary syndromes, such drug-eluting stents are indicated based on an individual basis, taking into account baseline characteristics, coronary anatomy, and bleeding risk. This is also a 1A recommendation. What should not be done in such patients? You should not perform a percutaneous intervention with or without stent implantation in non-significant lesions, and you should not do routine invasive evaluation of low-risk patients. So these patients first should have stress testing. This slide gives you indications for bypass surgery versus percutaneous intervention in stable patients with ischemic heart disease. And as can be seen, the best recommendations, 2010, this slide goes back to the myocardial revascularization guidelines, here are given for bypass surgery. But you can see also on the right-hand side that there are clear indications for PCI, for example in patients with a non-proximal LAD lesion and a 1 or 2 vessel disease. And there are also indications, not as good as for surgery, for patients with proximal LAD and 1 or 2 vessel disease, and for simple 3 vessel disease, full functional revascularization achievable with PCI, and patients with a so-called syntax score of less than 22. This is only 2AB recommendation, but 2AB for interventional cardiologists means that this technique is preferred over surgery. There's only one clear warning with respect to surgery. This is the 3 vessel complex lesions, incomplete revascularization achievable with PCI, and a syntax score of more than 22, because here all the data show us that bypass surgery is better than PCI, but these data come from 2010, and there are a lot of studies going on which will show us whether PCI will also improve in this special subset of patients. With respect to left main interventions, again you can choose between surgery with a somewhat better recommendation and percutaneous intervention, but as I told you, an interventional cardiologist would choose the interventional part and not send most of these patients to his surgical colleagues. However, if there's a left main narrowing at 2 and a 3 vessel disease and patients with a high symptom score, here again the recommendation is for surgical procedures. This is a checklist of antithrombotic treatments prior to PCI. And beside aspirin, which is at the moment the standard antiplatelet therapy, we also should use so-called ADP receptor blockers or P2Y12 inhibitors. And here we have 2 options. The European guidelines tell us that we should confirm a loading dose of ticagrelor in these patients, which seems to be better than clopidogrel prior to PCI. There's also an option to use prasugrel as one of the new ADP receptor blockers in this situation, but only in so-called clopidogrel naive patients and as long as the coronary anatomy is known. A clear contraindication exists for prior stroke or TAI, while patients with an age of more than 75 years or less than 60 kilograms can be treated with prasugrel. There's no clear contraindication, but it's frequently not done. With respect to anticoagulants, we have several options. We can use fondaparinux. In this case, as soon as the patient comes into the cath lab and the PCI is performed, we have to add unfractionated heparin or bivalirudin, because fondaparinux alone wouldn't be strong enough in this situation. We could use enoxaparin, and then we would stay on enoxaparin during the catheter procedure. Or if patients are pre-treated with unfractionated heparin, we could also stay on heparin or switch to bivalirudin as given on this table. With respect to 2B3A receptor inhibitors, we should consider tirofiban or eptifibatide in such patients with high-risk anatomy if there is a high thrombus load. Not in all patients with troponin elevation, this has been made clear in the past, and also a pre-treatment of patients with non-ST elevation MI before the cath lab is no more recommended. Reapro should only be given to patients with highest risk during coronary intervention. So what are the performance measures in non-STEMI patients? What is necessary to think of? The use of aspirin, the use of one of the ADP receptor blockers, whereby for non-ST elevation MI patients, ticagrelor is to be preferred over the other substances. The use of unfractionated heparin, enoxaparin, fondaparinux, or bivalirudin, depending on the individual situation. A beta blocker at discharge in patients with left ventricular dysfunction. The use of statins, and here high effective, high dose statins have to be preferred. The use of ACE inhibitors or angiotensin receptor blockers. Smoking cessation advice and counseling, and enrollment in a secondary prevention or cardiac rehabilitation program. Especially important, the use of early invasive procedures in intermediate to high risk patients. Now my take-home messages. The timing is important of revascularization customized according to the risk of the patient. Within 72 hours in all patients at risk, but within 2 hours for very high-risk patients with life-threatening symptoms. Eventually within 24 hours for patients with high-risk criteria like a high-risk score, troponin release, or CT changes. We should prefer drug-eluting stents for PCI in these patients. and if patients are of low risk. A non-invasive evaluation should precede an angiogram and further diagnostic and therapeutic tests. Thank you very much for your interest. I think there will be a place. Cangrelor is one of the new P2Y12 receptor inhibitors, and a huge advantage of this substance is that it can be given intravenously, so it acts immediately as soon as it's injected. And this is an important feature because we know from clopidogrel, from prasugrel now after the ACCOST trial, but also from ticagrelor, that the action is not immediately there if it's a perioral agent. So it might last 2-3 hours until an optimal action of the substance with respect to antiplatelet therapy is reached, mainly based on the hemodynamic situation of the patient. So if there is some depression of the hemodynamic situation, you might also expect a low reabsorption, and then the drug works later than expected from healthy volunteers. So this is why I personally believe that Cangrelor is an ideal substance for an acute use, and also with respect to an eventually necessary bypass operation, this substance is of interest because if you stop the infusion within 1 or 2 hours, there's no more action left, and so you can really bridge the patient until close to surgery, which might be an important feature for some of our patients with non-ST elevation acute coronary syndromes.